Hey everyone, it's Adam again, and we're going to go over another lecture here in the Biostats course, continuing on our talk of epidemiology. Today we're going to talk a little bit about data sources and measurements. The objectives, we'll cover these in order, but you can read those at your leisure. So when looking at epidemiologic studies, it's important to know that when you're looking at like rates of events occurring or things like that, it's important to know, kind of what the numbers are referring to. In a lot of cases, the denominator typically is kind of defined by the population that is at risk. Oftentimes you can use things like census data that can help with this. Otherwise, if you're using a more specific population, you would use that as your denominator. It would be all the people within that population that would be considered at risk. The numerator typically is going to be defined as the people who have the event or the condition of concern, right? And so we gather this information from things like birth data, death registries. You can do surveys, reports to things like the CDC, all kinds of different things. Whatever event you're actually concerned about is going to be going in the numerator. So again, it kind of tells you, what's that rate of the event occurring over the total number of people who happen to be at risk for that event. Now, most nations typically do census data periodically, usually every 10 years or so. So we're actually going to be up for another census in 2020. And so this gives us a lot of information about kind of the characteristics of the population of the U.S. Gives us a lot of information that you can see being used for epidemiologic studies for kind of years to come, usually until the next census is done. There's also different types of reporting systems that can help us to collect data about things like births and deaths and all of that. And so using these, we call these vital statistics systems. They also utilize recent census data for helping with things like denominators, death rates, things like that. So there's lots of sources of information here that we can use to help us kind of figure out what our kind of denominator is going to be in a lot of these cases. Now, not every country is going to be able to record their census data as effectively as others, and so if you want to do things like making international comparisons for things like infant mortality rate's a really good one, because we use that as an example for kind of a surrogate for overall health of the population, like how well are we taking care of the moms, how well are we taking care of the infants, and so again, by making comparisons, it's important to make sure you're comparing apples to apples. And so if countries are not taking very good counts of these things, it's more difficult to kind of make those comparisons appropriately. And again, there's a website here you can go to where they actually give you, all the kind of official data that's available, and it gets updated pretty regularly. Now, specifically with the U.S., we find that a lot of things like birth and death data typically gets pulled from different sort of health-related public data systems, and so you can find that these occur at a local level, state, and also can rely on national agencies as well. Things like birth rates initially get collected by the hospital, when birth certificates and things like that are being signed by like physicians, and then get transmitted to the appropriate outlets. Usually things like Department of Health, etc., can then channel that information up kind of from a more kind of local to state to more kind of national sort of pathway there. The same thing can happen with death certificates as well. Usually that being completed by like a physician. In some cases it can be a medical examiner who also is a physician, or a coroner in some cases. So how some of this can be funneled, especially with like birth and death certificates. You start with this kind of local jurisdiction. They usually maintain, the information usually in perpetuity, and then they get funneled up through the kind of state governments. Like I mentioned, the state health departments are a big one, and then that gets funneled up through a branch of the CDC called the National Center for Health Statistics. And so they prepare kind of national summaries, and again, that information is generally available for all people. So if you wanted to use that for a study you were doing, for an intervention on things like birth rates and death rates, anything like that, that information is available to you, which is pretty handy, and it can be utilized for things like international comparisons, etc. And so, as I mentioned previously, the U.S. Census is done by the federal government and gets done every 10 years. And so this is very useful because it helps us to generate things like projections to give us an idea of like what's the size of the population going to be in another 10 years based on kind of previous rates and things like that. So it's going to be a very useful set of information. You see it used in a lot of different type of epidemiologic studies. So the reason why we use this kind of national information is because we can apply this back to clinical epidemiology, where we're usually going to be focusing on a much smaller subset of patients. And so when you're doing clinical epidemiology, a lot of that data comes from things like examination of the patient, if you have clinical records available, or if you have any kind of specific studies being done in a particular population that you're interested in. Now, the nice thing about these national studies that are done is when you have these really large populations, you can utilize that information, especially to apply it back to, say, your smaller data set. This usually helps to reduce costs pretty significantly, and will speed up the answers when you're looking for whatever your clinical question happens to be. So it's very useful to utilize this information and try to take that back from a national level and apply it back down to your patients that you're interested in. So it's really important to understand that these analyses are only going to be as good as what the actual data that's collected is. And so you can have lots of sources for error in this. So for instance, if you had, say, unreported births or deaths, a really big one you can see is inaccurate death certificate diagnoses. One of the things I found very interesting is for a different class I was teaching, we got to do a field trip to the medical examiner's office, and we were actually talking to the medical examiner there, who's a board certified physician, clinical pathologist, and they were actually saying that in Florida we only use medical examiners. So if there's a question about the death of a patient, it gets referred back to the medical examiner's office. So there's always a physician who's reviewing that information and can make kind of a lot better clinical kind of assessments on the cause of death for a patient, as opposed to a coroner, which actually places like Georgia utilizes coroners, and they actually don't have to have really hardly any training. It's a very short amount of training they need to be able to become a quote-unquote coroner, versus a medical examiner who has to go through medical school and residency and all these other things. It's just kind of interesting to see how even from state to state you could have very vastly different information being reported based on the accuracy. In addition to that, you could also have erroneous, demographic information, or if the information for birth and death certificates was erroneous in any way, dates were missing or recorded inaccurately or anything like that can be potential sources for error. Another really important source of information about especially contagious diseases are going to be at the National Notifiable Disease Surveillance System. And this is actually a program run by the CDC where clinics, hospitals, etc., they are required to actually report cases of certain diseases, especially infectious diseases in most cases, but also some non-infectious diseases, up to the CDC, usually through the kind of local state health department. So again, if you had a case of, say, meningococcal disease at, say, a hospital in Florida, you'd report that up to the Florida Department of Health, who eventually would report that back up to the CDC, which, as you know, resides in Atlanta, Georgia. If anyone's ever seen Walking Dead season 1, you'll definitely know that. But anyway, so once that is done, there's usually some sort of epidemiologic investigation that gets done for possible outbreaks. So again, if CDC started noticing that, several hospitals in Florida reported meningococcal disease, that could represent some sort of outbreak or, kind of an epidemic that's starting up. So that's why it's so important to make sure that the reporting of this is done accurately and the appropriate investigations can be done, right? So not only from a local standpoint, but also from the state and potentially federal level as well, right? So certainly you don't need to memorize this entire list, but this is just an example of the different diseases that can be reported up through the CDC. And again, they will take this information and potentially do an epidemiologic study to try to figure out, hey, is this something that's just a kind of a one-off event, or is this something that is more widespread that we need to kind of nip in the bud early before it becomes even further widespread? So unfortunately, what you find is only a fraction of these disease cases actually end up getting reported. Generally, what you find, it could be related to things like underdiagnosis. In a lot of cases, you may find that really only the most extremely serious cases or diseases, things that are very rare or things that can become very severe or like lead to death, tend to get more reported. So for instance, if you had a paralytic poliomyelitis case, that probably is going to get reported because you don't really see that every single day. And then also there's some hesitancy with reporting certain types of infectious diseases. For one thing, HIV, you may feel less likely to report that due to things like social isolation, in the same vein as that, STDs, tuberculosis, whatnot. So again, typically you find these diseases are underreported unless they are particularly severe or particularly rare, in which case you're much more likely to end up reporting that. So as I mentioned, the more common a disease is and the less serious it is, the more likely you are to see underreporting of it. The reporting that does happen can still be somewhat useful, particularly if you're looking for things that like, diseases that can be prevented by, a vaccine. So for instance, if you're looking at things, like pneumococcal disease or something like that, you want to know if the vaccine's not actually working. So, as long as the rates of reporting tend to be pretty constant, the pattern that kind of gets revealed can be useful, even though you may not have the actual true numbers there, because they're actually kind of reflecting those trends, not necessarily the absolute number that you'll see there. Now, certainly infectious diseases aren't the only thing we're looking at. There's also behavioral monitoring you can do. And these are usually things that are done by things like telephone surveys and whatnot in different slices of the U.S. population. Obviously, we can't call everyone to see if they're smoking or not, but by doing these sort of slices of the population, you can kind of see trends in different locations and along different time periods and things like that. And so you can look for things like exercising, smoking, obesity, etc. And even looking at certain subsets of the population. For instance, as a effort of this behavioral risk factor surveillance system, there's a youth risk behavior surveillance system where they look specifically at children and young adults to see, what kind of high risk behaviors are they participating in that can potentially impact their health. Another potential source for information for all these epidemiologic studies come from actual third-party payers. So these are insurance companies who oftentimes represent or have thousands upon thousands, possibly millions of clients that they can have this information that's available. And typically, since they're paying for healthcare, they have pretty good access to the information. And we get a large amount of information from this, and many studies get done through these programs. So Medicaid and Medicare for sure, the Veterans Affairs System, Kaiser Permanente, which is a very large insurance company. We can use this, or that data can be used by clinical epidemiologists and healthcare researchers who, they're kind of concerned about things like, the cost effectiveness of medical care. Because obviously if you're an insurance company, like you want to make sure that you're providing the most effective care for the cheapest amount of money possible. So a lot of economic studies are done through this kind of information to see like, okay, well, we did this sort of intervention, how much did it cost and what actual benefit did we get from it versus say another intervention. So that's kind of the sources where we get a lot of our information. Is where we get some of our information about denominators especially. But let's look at different epidemiologic measurements. So frequency is going to be one of the first measurements we'll talk about. As you might imagine, frequency of a disease, it could also be injury, death, whatever your outcome happens to be. And it can be related back to different denominators, depending on your research purpose, depending on your clinical question, or just on the availability of data. Again, your frequency is typically going to be that numerator applied to whatever denominator you choose or the researcher has chosen. We have incidence, which is a type of frequency, and this is going to be the occurrence of disease, injury, or death, or again, whatever your definition is going to be in that study population during the time period of the study. Okay, so this would include, like, say, the number of transitions from well to ill, from uninjured to injured, or from alive to dead. This is something that oftentimes gets used incorrectly. Incidence is not going to be the same as incidence rate. And so what we'll look at here is when we're referring to this, we'll probably say the term incident cases rather than just incidence by itself. This is usually something where you're kind of looking forward in time. So you start at time point 0 and look forward, looking at the incidents or these new cases that are starting to show up. That's kind of what we're looking for when we're seeing incidents. Prevalence, on the other hand, or sometimes is referred to as point prevalence, is usually at a particular point in time. And again, a lot of times this is done kind of retrospectively. You are seeing the number of people within that defined population who have the outcome that you're concerned with. So again, you're kind of looking back and saying, okay, well, in 2010, how many people in the US had HIV? Versus in 2015, how many people had HIV? That would be a prevalence, because you're looking at that total population you're concerned with, how many people actually had the disease at that time, as opposed to newly developing the disease, which would be more referencing incidence. As I mentioned, similar to incidence, prevalence sometimes gets used incorrectly. When we're talking about prevalence rate, we'll kind of delineate the difference there in just a little bit. But we'll also basically be terming this as prevalent cases as opposed to just using prevalence by itself. So again, I'll probably use them interchangeably, but again, just be careful when you're looking at the rate versus just prevalence by itself. We'll look at what the difference is in just a little bit. So the difference between point prevalence and period prevalence, basically what this means is that when we use the term prevalence, usually point prevalence is going to be meant in a lot of cases. Basically, you're talking about at one single point in time. So say, for instance, December of 2010. Period prevalence is going to refer to the number of people who had a disease at any time during a specified time interval. Okay, so basically that period prevalence is the sum of the point prevalence at the beginning of the interval plus the incidence of new during the interval itself. So basically, if you were, say, starting at time point 0, say we're here in the future, or say at the present, I guess would be in this case, and you're looking backwards, if you're looking at the number of people who had disease here at the start point of your study, this would be considered your point prevalence. So again, this is the number of people out of your whole population that you're concerned with who had the disease in question. And then you would add to that, for the period prevalence, the number of new incident cases moving forward. So say you had a new case here, 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 and here. These 4 points would end up being added on to that initial point prevalence there. So that would be considered period prevalence. It's just adding that point prevalence plus the new incident cases that come up during that time point. And because period prevalence is kind of a mixed measure, because we're kind of using incidence and prevalence, it's not going to be ideal for a lot of scientific work. Most of the time, you're either going to be looking at incidence or prevalence kind of by itself. So the next slide is going to be useful because it's going to kind of illustrate these different concepts we've talked about, namely incident cases, the point prevalence or those prevalent cases, and then that period prevalence we kind of mentioned here. So what you'll see in the next slide is going to be basically data concerning 8 people in a defined population where there's going to be no one leaving or no one coming into the population. So that denominator is going to stay the same. Okay. Each case gets referred to as a case number 1 through 8, and then you'll see that a line begins when the person becomes ill, and then if they recover or they die, that's when the line is going to end for that person. Okay. T1 signifies the beginning time period, and T2 signifies the end of the study period. So here's the table I was referring to in the previous slide here. So you can kind of notice this is over a 1-year time period. So here's T1, beginning of the study, versus T2, the end of the study. And beginning of January 1 all the way to December 31st, right? You'll see that each of the people are given a case number, so 1 through 8 here. And then you'll see that if someone had a disease, say, the entire time, as in case 1, you're going to see it's going to basically span this entire time period. So basically they had a disease the entire year, did not recover, did not die. As opposed to someone like case 4, where they actually became ill during the study period and they either recovered or died during the time period, right? Versus 5, who's someone who became ill during the time period and then never recovered by the end of the study. So we'll look at some points related to this in some upcoming slides, but I just want to get you kind of acclimated to the table to begin with, the graph to begin with. So as I mentioned, in case number 1, the patient was ill when the year began and was still alive and ill when it ended. As opposed to cases number 2, 6, and 8, those patients were ill when the year began, the time period started, but they ended up either recovering or dying during that time period. 3 and 5, on the other hand, they became ill during the time period, but then were either alive, or were still alive, I should say, and ill when the year ended. That's why they don't have any of those little black endpoints on there. They continued on past that end of the year. And then for 4 and 7, they became ill during the year and either recovered or died during that time period. So you can kind of get a good idea for the different types of beginnings and endings for disease you can see on this table. So on the basis of the illustration, basically we can make the following calculations. So for instance, we were looking at the incident cases during the year. These would be cases of new disease that occurred during that time period. I mean, new incident cases that would be considered to be 4, right? So it was number 3, 4, 5, and 7. Okay. The point prevalence at T1, so this was how many people actually had the disease at time 1, beginning of the study, was 4. Basically, the prevalent cases there were number 1, 2, 6, and 8, right? So they all started the period T1 actually having the disease. Now at T2, the end of the study period, you could also make a point prevalence, because then you just count up how many people actually had the disease at the very end of the study, and that would be 3 in this case. It would be numbers 1, 3, and 5. The period prevalence, though, is going to equal the point prevalence at T1, the beginning of the study, plus the number of new incident cases between T1 and T2. In this case, it would end up being 8. So we'll look at that in a second. I'll kind of show you how to figure that out. But basically, you're looking at the 4 incident cases. So again, these are new cases that happen, plus that point prevalence at T1. So again, that would make sense how you're getting 1, 2, 6, and 8 plus 3, 4, 5, and 7. So again, all 8 of the people will be counted in that. So although a person could be an incident case only once, he or she could be considered a prevalent case at many points in time, including the beginning and the ending of the study period. So as with case number 1, they would be considered to be a prevalent case no matter what time period you actually took that out of, because they had the disease the entire time here. So if you were to look at this, and you can do point prevalences kind of anywhere you want. So if you did it at T1, obviously the point prevalence is 4. However, if I were to say do somewhere in say June or July, and I were to look at the point prevalence, you can basically kind of just look at it as, how many lines do I cross going through the middle of the year. Sorry, it's not super straight line. Would not be very scientifically accurate, but you can see your point prevalence right at the middle of the year would be 1, 2, 3, 4, 5, and 6. So 6 out of 8 would be your point prevalence if you did this, say, in June or July, right? So hopefully this kind of makes some sense, and you'll see these in epidemiologic studies when they refer to incident cases, point prevalence, period prevalence, things like that. So here's another example of using incidence and prevalence. And so this is some data that was reviewed from the CDC using cases of AIDS in the US from 1981 when it was kind of first recognized up through 92. After which time they saw that you can't really make good comparisons afterwards, because we actually had a change in the definition of what gets constituted as AIDS. And so because of that, any of that data kind of become not very useful, because people who may have been counted or not counted in say 91 may have been counted after that 92 time period. So again, we're just looking at between 1981 to 92 when we're kind of illustrating these incidences and prevalences. All right, so to kind of acclimate you to this slide here, kind of go over a few things. So obviously on the y-axis here, we have our number of reported cases of AIDS. And on the x-axis here, we're going to have different years. And so this N is going to be the total number of cases of AIDS that were reported during this study period. Again, going from 81 to 92. Basically, the dark bars, actually the full height of the bar would be all the new incident cases of AIDS that were reported during that year. Okay, the black sections of the bars are going to be people that were known to be dead at the end of the time period in 92, right? And the white portions of the bar were going to be those known cases that were diagnosed during that year that were still alive at the end of the time period in 1992. Okay, so for instance, you notice here that a few people are being diagnosed, and that's probably because it's a very new disease. They're just now starting to recognize it. Maybe a lot of people weren't really coming forward or didn't really diagnose it appropriately. As the diagnosis got better, you had more and more people that were starting to be considered incident cases for that particular year. But you'll notice that many of them died, especially early on, either due to presenting with very progressive disease or the treatments weren't very good. What you notice is that as time goes on, these white sections of the bar were larger, and this is mainly due to people either having kind of earlier onset of the disease, were catching it earlier, so they were living for longer, or just due to the fact that they were diagnosed very close to when the actual cutoff for the study was done. So again, any people who were diagnosed in 92, they probably lived to the end of 1992, as opposed to people that got diagnosed in 1981, where there's very little treatment that was available to them. The other aspect of more people living is generally due to treatment being better. Okay, so again, let's look to see how we can apply these principles of prevalence and incidence to this information now that you've kind of been acclimated to it. So this slide just kind of summarizes what we said on the last graph we're just looking at. Again, the full height of each year's bar is going to be that total number of new AIDS cases that were reported to the CDC for that year. So again, for that incidence, each year is going to be the full height of that bar. The darkened portions are going to be the number of patients in whom AIDS was diagnosed in that year, but then were dead by the end of the study period. So it was 12/31/1992. The clear space in each bar is going to be the number of people who were diagnosed in that year and who presumably were still alive. They were not reported to be dead. And then that sum of the clear area, actually, if you added them all up, would be the number of prevalent cases of AIDS as of the end date, right? So if you were to add up all the previous clear bars together for a particular year, that would be the number of prevalent cases, because those are people that were diagnosed but still alive, right? So they were considered to be that would be prevalence as opposed to incidence. So of the patients in whom AIDS had been diagnosed between 1990 to 92 and who had the disease for a relatively short time period, many of them were still alive, as I mentioned, at the cutoff date. Again, either due to kind of recent infection or due to improved treatment, more drugs that were available, more kind of recognition of the disease. But almost everyone who was diagnosed in the first 6 years had died, again, mainly because they were probably presenting very late or they did not have very good access to treatment, or there's just no treatments available. So what you can see is that the total number of cases of the epidemic disease reported over time is going to be that cumulative incidence. So again, that N that we were looking at in that table, or that graph, I should say, would be the cumulative incidence, because those are all the cases of AIDS that got diagnosed during that study period. And so, again, when you're looking at that cumulative incidence of AIDS cases, the time period was 206,000, right? The number known to have died was 133,000. So if you were wanting to see what the prevalence was at the end of the study period, you would see that it would be 73,000 people, because basically you just take the actual incidence, cumulative incidence, and subtract the number of people that had died from that. So those are, the 73,000 were all the people who were left alive, essentially. And of course, if they had died, say, in subsequent years, they would have been removed from the prevalent cases category. But because we only went up to 92, they were still considered to be alive and considered to be prevalent at that point. So again, kind of showing you that, again, all these people ended up dying kind of early on. These are still considered incident cases. So the total number of incident cases together, cumulative incidence, would be 253,000. When you add in the 92, if you were to subtract all the dead from it, that's when you get the prevalent cases. So basically, if you added up all these white bars together, at the end of 92, this would be considered your prevalent cases. So as I mentioned, the study kind of ended at that time period because the CDC made a big change in how they were defining AIDS. And so you may have had people who had actually had the disease, but maybe not have been classified as such. And so they may have been underreporting in a lot of cases of actually how many people had AIDS. And as such, you're going to see a really big spike that occurred here in 1993 due to all these additional cases now being reported. And now, so the new, more recent data, not going to be as satisfactory as the older data for kind of showing that illustration between incidence and prevalence, because all of a sudden your incidence just went, through the roof essentially. And so you can see on the next slide here how, we can illustrate just how important concept the consistent definition of a disease is going to be to make fair comparisons of trends and those rates of disease over time. So you can see here, this would be the reported cases of AIDS in the U.S. And then going by quarter through the different years. You can see it goes through, pretty consistently increasing. And then all of a sudden, when you get to 93, we change the definition. All of a sudden, a ton of people got reported, right? Because that is very difficult to make any inferences about the changes in rate based on these new definitions, because a lot of these people were probably still had the disease, they just weren't being captured. And prevalence can be affected by several factors. So you can see things like just the periodic or new number of cases that get reported. So again, it'd be kind of the ongoing incidence can affect prevalence. If you have immigration, you have new people with disease coming in, or immigration, or people with the disease that are leaving the population, that can definitely change things. And then this average duration of disease, so from the time of onset, the disease until death or the healing occurs, can affect prevalence as well. Obviously, if there's a new treatment that comes out and shortens the disease duration, that can affect prevalence pretty significantly, right? So what we can see is that there's a formula we can use, kind of a general formula for prevalence that's pretty conceptually important for understanding and trying to predict the burden of disease on a society. So again, this isn't an exact count, but you can try to predict what the prevalence is going to be. And basically you end up taking the incidence. Again, you're using kind of historical data for this, like what the new incidence of the disease is, kind of on average, and you're multiplying this by the average duration, and that should give you an idea of what the prevalence would be at a given point in time. And again, this is an estimate, but it is good for kind of giving us ideas for things like projections of how many people presumably might have a disease down the road. So this formula really only works if the incidence of the disease and the duration for those individuals stays pretty stable for an extended time period. If it changes pretty rapidly, then those kind of projections or those kind of estimated prevalence isn't going to be super useful for our purposes. The information just isn't likely to be accurate. But the way we can apply this back to our AIDS cases, our AIDS information we were looking at, is the fact that prevalence of disease can go up pretty significantly for a disease like AIDS, mainly because of the fact that you may have an increase in the yearly numbers of new cases, not even necessarily due to disease spread, but also due to things like increased awareness or more people getting checked, things like that. And also the fact that we have better treatment nowadays is the fact that people will live for longer with AIDS. We know that. And the fact that, they will not necessarily recover because they're always going to have the disease essentially. But you may find that they live for longer or survive for longer before, dying, right? In other diseases, they may recover, but with these patients, the prevalence is only going to be increasing because these patients are living for longer. So any time period, more people are going to have the disease, more people are being more prevalent. So just to illustrate that, the incidence of AIDS is going to be declining, right? Mainly because we have, a lot of, very good interventions from a public health standpoint. We are more awareness is out there about the way that AIDS can spread. So there are lots of things that are actually decreasing the new incidence of AIDS that is occurring. But as I mentioned, the prevalence is generally going to be going up, mainly due to that duration of life is going to be much longer. So a lot of that's due to things like antiviral agents, better prophylaxis against AIDS-defining illnesses, and things like that. And so what we find is that the increased length of survival, it tends to be proportionally more than that decline in incidence. So the prevalence is tending to increase in the U.S. as time goes on. Another good example of this would be something like cardiovascular disease mortality. Now, if you were looking at age-specific incidence, again, so it's taking age into account, that has been declining in the U.S. in recent decades. But on the other hand, the prevalence really hasn't. And a lot of that has to do with things like, advances in technology, so things like, percutaneous interventions, things like newer pharmacotherapies. They tend to increase life. So the number of people who have the disease tend to live for longer, right? So again, you can see these changes happen all the time based on treatment, based on changes in incidence and whatnot. So just be aware that these different factors can play into not only the incidence of disease, but also kind of the overall prevalence amongst the population. So here's another important concept we're looking at, and this is termed risk. A lot of people wonder, like, well, what's my risk of developing disease, over a particular time period? And this is where a lot of these epidemiologic studies can be useful. So basically, risk is what we're going to be using to define the proportion of people who are unaffected at the beginning of a study period, but who undergo the risk event during a study period, right? So these are people that start off healthy at the beginning of a study, and the risk is going to be the number of people who actually develop that period or that event throughout the study period, right? So we can classify this many ways. It could be death, could be a particular disease, injury, all of that. And basically what we're going to call the people who are at the beginning of the study, who again are initially unaffected, this is going to be called our cohort. And so, if we have an investigator who's following all the persons in a cohort, and you're looking over a several year period in a lot of these cases, that denominator for the risk is going to be not really changing, right? Because again, you're always going to have the same people who began the study, as long as they're not lost to follow-up and cannot be included in your statistics. But in a cohort, you're going to find that the denominator, again, if you were looking at whether it's 5-year risk, 1-year risk, it doesn't really change because, again, the number of people who joined the study at the very beginning hasn't really changed at all. So the denominator stays the same, but the numerator may change as time goes on based on people who undergo the event. So care is needed when you're trying to apply some of these risk estimates, and again, these are derived from populations. It's difficult to apply that back to an individual patient, and so if someone does have one of these events, everyone, the risk of death for people is 100% because everyone's going to die at some point, right? But the best way that we can approach this, especially when patients have questions, are going to be regarding risk related to things like surgery, is not going to give them a number. You don't want to say, hey, your chances for survival are 99%. they're going to get pretty freaked out when they think they may be the 1%, right? It's one of those things where you want to be a little bit more careful with your words to make sure you don't kind of give them the wrong expectation. You're better off kind of putting the risk of surgery in the context of many other risks you may take frequently. So for instance, long automobile trips tend to be particularly dangerous as well, if you consider the numbers, but most people don't feel too uncomfortable with doing that, right? The real issue here is going to be whether those patients are willing to take any risk to achieve the potential benefit of surgery, right? So again, with any kind of medical intervention, pharmacologic or otherwise, there's always going to be potential risks, and so we need to make sure we're kind of looking at, see like, well, what are those risks, and what are the potential benefits we can reap from this, and how do we kind of convey that to our patient to make sure that they feel comfortable, kind of agreeing to our treatment plan. So, and again, often it's difficult to be sure of the correct denominator for a measure of risk. The question is who's truly at risk for an event? Is there particular genetic difference, or is there some kind of risk factor that may make someone more at risk? It's one of those things where you're looking at, like, pregnancy. Well, only women are going to be at risk for becoming pregnant, so there's no point including guys in these kind of studies. So your denominator is going to change, right? And even further than that, you have to look more specifically, well, who's of childbearing age? You don't want to include a woman who is age 2 because they're unlikely to get pregnant. Similarly, someone who is 75, very unlikely to become pregnant. So, you may look at your denominator as being only women who are age 15 to 44, right? And even then, you may get more granular because you may have a proportion of those people who are not at risk of getting pregnant due to things like hysterectomy, or maybe have other reasons that they happen to be sterile. So it's important you try to define who the truly susceptible population might be. And this can be especially difficult for things like infectious diseases, right? Ideally, for an infectious disease sort of risk, you only want to look at that susceptible population. So for instance, you don't want to look at people who have antibody protection. People who have, like, say, the vaccine, because they probably wouldn't be really at big risk for developing that disease. So you want to count those people without protection in the denominator. And so typically what we see is kind of a compromise here. That denominator is going to consist of either a total population of an area or people or an age group who probably lack the antibodies, right? So again, you will never have all the absolutely accurate information, but we try to make compromises and kind of get as close as we can within reason. When looking at risk, infectious diseases can be pretty complex, especially because, again, there's numerous subsets of the population you really have to consider. And so, for instance, when you're looking at something like, this risk, you have to look at, first off, okay, well, who are the people that died of an infectious disease? It's a pretty small subset of people. And then you're looking at, okay, well, then who are the people that actually became ill from the disease? Notice it's kind of a larger circle here of people that you're including. Those who actually became infected but maybe never became ill, right? And then those that maybe were exposed to the infection. Again, we're looking at smaller and smaller subsets, or larger and larger subsets, right? And then those who are susceptible to the infection. And then eventually you have the entire population. It could be even a much larger subset than that. So again, you have to be very clear with your definitions, or researchers should be clear with their definitions to make sure they're defining kind of who they're looking at, because you want to make sure you're looking at the right subset to make sure the risk is appropriate. So when we're looking at these different kind of subsets, we can see that the proportion of people who are clinically ill, who develop the disease, and who die, this is going to be considered our case fatality ratio, right? So people who became ill and then died, or is that case fatality ratio. Typically, the higher the case fatality ratio is, the more virulent the infection. And then when you're looking at the proportion of infected people who became clinically ill, so again, this is that larger subset of people who maybe became infected, but then those who actually became ill is going to be called the pathogenicity of the organism. So obviously a higher number of people who were infected and then became ill would have a higher pathogenicity. Okay? And then those who were exposed and then became infected is going to be considered to be the infectiousness of the organism, right? So just because you became infected doesn't mean you're going to die. That can be informed by things like case fatality ratios and looking at the virulence and the pathogenicity and all of that. So again, this is another probably better example than my poor drawing was, but essentially, again, you're looking at the total population here. These are people who may have been susceptible, so maybe people who were not vaccinated. And again, this is considering this whole group here. All these people are included in kind of the slice of the pie. You have those who are exposed. Again, not all of these people got infected, right? They may have an exposure, but no infection occurred. Then you have those who were infected, but maybe didn't become ill. and then those that became ill that did not die, and then those that obviously experienced all of the events here and eventually died. So this concept of risk really has a lot of limitations to it. And so, for instance, when you're looking at rates of disease or rates of death and how that influences risk, let's say, for instance, we're going to look at 3 different populations. They're all the same size, and they have all the same age distribution. Say, for instance, we're looking at 3 nursing homes, and they're not going to have any new patients during the study periods. They're all booked up. They all have the same populations here, essentially, as far as age and the number go. And let's say they all have the same overall risk of death during the same year, so 10%. I don't know if I'd want to send my mom to a nursing home with that 10% death rate, but let's just say for our purposes here, it's 10%. And again, we're going to go from January 1st to December 31st in, say, year 2017. Okay. But we'll look at this graph here in a second here, but looking at this, despite the similarity in risk, right, they all have a risk of 10% death during that year. If you look at the deaths in the 3 populations, they may occur in very different patterns over time. So we look at this graph. Suppose that population A had a really bad influenza epidemic in January, so at the beginning of the study year, and then most of those who died during the year died within the first month. So all that 10% died very early on. Suppose in population B that the epidemic did not hit them. They did not get the influenza epidemic until the subsequent year. Maybe they all got a really good vaccine, the prior December, but now they did not get hit with this new epidemic until the December. So most of their 10% was lost in the following December at the very end of the study period. And then finally in C, they were never hit with an epidemic, and then basically all the deaths occurred very evenly throughout the year. So again, they lost pretty consistently throughout the year. So again, when we're looking at this, that 1-year risk, that 10% would be the same in all 3 populations, but what we consider to be the force of mortality would not be, because again, the deaths are occurring at very different time periods or very different rates depending on when these different events occurred. What you'll find is that force of mortality is going to be greatest in population A, because most people died very early on. And population B is going to be the least, because most everyone died at the very end. And then it would be kind of intermediate in population C, because they're very consistent throughout the year and who died. So because the fact that risk doesn't really tell us anything about when these people are dying, what's really more important is going to be a more precise measure, and this is going to be considered rate. Okay, so rate is going to be important in how it kind of goes back and kind of informs us about risk. It gives us a more kind of precise idea of what kind of these patterns of the event occurring, death in this case, happens to be. So looking at this, you can see our time period here on the x-axis going from January 1 to December 31st. We can see here that this is the total number of people who are surviving in each of these populations. All of them are going to have 10% mortality. So at the very end, they're all kind of ending at the same time, or same number of people still alive. 90% are still alive. But you can notice here in A that most people died very early on. That 10% dropped off pretty quickly and then ended up at the end point. C, again, was very consistent throughout, so we're kind of losing people all the way throughout the year. And then B, they did not get hit by the flu until the very end of the year. So rate's going to be very useful because it can kind of give us a little bit better idea of what these patterns of disease were, patterns of death were in this case, versus just looking at this 10% mortality risk, right? So how we calculate the rate is basically we're going to look at our frequency, or the number of events that occur in that time period, whatever we define it to be as. And then that's going to be our numerator. And then we're going to divide it by the average number of people who happen to be at risk during the period being studied. Now, because we saw that the number of people at risk at any time point changed pretty significantly between population A, B, and C, what we can use as kind of a surrogate for that is going to be our mid-period population. So basically at the halfway mark, what were the number of people that were there in that population? And that's usually considered to be a pretty good estimate of the average number of people at risk. And you can put that in the denominator. And so when you're looking at this kind of the formal structure, the actual calculation, you'd see that rate equals that numerator divided by the denominator times this constant multiplier that we'll come up with. And again, most of the time the researchers will kind of will define what this constant multiplier is going to be and kind of how they came up with that number. So risk and rates usually have values that are less than 1, unless it's something where like an event can occur repeatedly. So if you're looking at like the incidence of colds or like asthma attacks, things are going to happen more than once. Like death usually happens once. But asthma attacks or something like that could certainly happen more than once. And so, as we mentioned, risk and rates usually less than one. It's pretty awkward to talk about fractions of a death. You can't really think about 1/1000th of a death per year to an event. That doesn't really make sense. So usually, what you do is you multiply it by some sort of constant multiplier, as I mentioned in that last slide there. Usually, it's either like say by 100, 1,000, 10,000, some sort of multiplier there. That way, it makes the numerator appear larger and then a lot easier to discuss. Essentially. So for instance, if you had 1 death per 1,000 people per year, it makes more sense than 1/1000th of a death per year, right? That way you can make it, okay, 1 death per how many ever people. It's much easier to discuss with patients and whatnot. And when that constant multiplier is used, the numerator and the denominator are multiplied by the same number, so the value of the ratio doesn't change. It just makes it more explicable to people. You can do this as well with like a crude death rate. So for instance, in 2003, if you're looking at the death rate in the US, you could calculate that to being 0.0086 per year. That doesn't really make sense to a lot of people. So if you multiply it by 1,000, you could say it's 8.6 deaths per 1,000 individuals. Similarly, you could say 86 deaths per 10,000 people in the population per year. But again, it's the same sort of calculation you see down here where you have the Start trying to get the laser pointer. But you have accrued death rate equals that number of deaths. Again, same place and time essentially. Whatever you define it to be as, divided by that mid-period population. Again, that say like in June or July, whatever that mid-period population is going to be, multiplied by 1,000. And so rates can kind of be thought of as the same way as velocity. So it's possible to talk about average rates or average velocity for a period of time. It kind of gives you an idea about different the different patterns that we're seeing, especially in that nursing home example. So looking at, say, the average velocity, we can obtain that by dividing the miles traveled. So for instance, if we're using a car example, we're driving 55 miles traveled by the time required by 1 hour. So we call that, say, 55 miles per hour. Doesn't mean that the car was traveling exactly 55 miles per hour for every instant during the hour, but on average equaled out to roughly 55 miles per hour. So similar to the car example, you could use these death rates. So you could look at, say, the rate of the event or death equal to the total number of events over your defined time period. So it could be a year divided by the average population exposed to that event. So say you had 12 deaths per 1,000 persons per year. You can do, or you can think of rate as kind of describing reality at an instant in time. So if you were to take it, at a certain point in time, you could call this an instantaneous death rate or a hazard rate. So you may see that term being used occasionally. So looking at a relationship between risk and rate in that nursing home example, we said that populations A, B, and C all had a similar size, and each of them had the same risk. They had a 10% overall risk of death in the same year, but we saw that the patterns changed pretty significantly based on when certain events occurred. So the next slide is going to demonstrate the 3 different patterns, and we'll illustrate how in the example the concept of rate can be a lot better, a lot more useful to the concept than just risk. Because again, the risk is the same between all 3, but this rate can help us to try to kind of show what that force of mortality is going to be. Again, looking at this, A was the group where they got hit early on in the year, so most of their 10% died very early on, versus B got hit in the end of the year, versus C was very consistent throughout the year and who was dying. All of them were 10%, but all happened in very different patterns. So essentially, because most of the deaths in population A occurred before July 1. This would mean, if you're using that as our midpoint population or our average population, basically you'd see that the cohort of A would have the smallest of the 3 populations, meaning that their denominator would be the lowest, meaning that their death rate would also be the highest, right? Because again, the numerator is going to be the same, but their denominator would have changed. It would be the lowest, so the total death rate would be higher. Looking at population B, they would actually have the lowest death rate, mainly because most of their population was still alive, at that midpoint population, versus them losing most of their patients kind of towards the end. So larger denominator, overall death rate is lower. And then the number of deaths before July 1 and the death rate for population C would kind of be an intermediate between A and B. Okay? So although the 1-year risk did not show differences, we're able to reflect this rate better by using, or we can describe these patterns a little bit better by using the rate and how the timing of deaths occurred in the 3 populations. And oftentimes rates can be used to estimate risk. this is with some caveats, obviously. So here we can see that the event in the numerator occurs only once per individual. That's kind of one caveat. You don't want these to be, rate will not be a good estimator of risk if it's something that happens, multiple times to the same individual. It's also going to be good if the population is only a small number of people are affected, generally like less than 5% or so, and the time interval that we're looking at. If you end up using something where you're looking at a very long interval, or the percentage of people who end up dying or having your event is very large, you'll notice that the rate actually ends up becoming a lot larger than your risk is, and so it's not as going to be accurate of an estimate. Now, if we're trying to look at something where the event occurs more than once, with something like an ear infection or an asthma attack, rate will not be a good estimator of risk. Basically, what we should use instead is something we call incidence density, which we'll probably talk about later on in this course at some point. And then the other thing, when you're looking at rate being a good estimate of risk, you need a short time period, because we'll see that even though the denominator for risk does not really change between a 5-year time period versus a 1 year, because again, you're looking at the same number of people who enter the study. The rate is not going to, that's not going to be the same for a rate, because essentially you're going to see the denominator changes depending on what kind of time frame you're looking at. So for rate, the denominator is constantly changing, and it decreases as some people die and others maybe leave the population or they immigrate. On the other hand, denominator can increase if you have some people immigrate into the population, or if you have others who are being born into the population. So imagine if you had someone who kind of immigrated into the nursing home community, that would change your denominator by increasing it, right? And so rate kind of reflects these changes by using that mid-period population as an estimate of the average population at risk, right? So you're trying to take into all these factors into account, and it's just an estimate. It's not perfect, but it kind of works for our purposes to determine rate. So as noted earlier, you'll see that rate tends to be a good approximation of risk if we're looking at a short time period. If it's long, that rate tends to be higher than the risk, because of the rate's denominator is going to be progressively reducing as the number of people by the number of people at risk events or deaths that occur up to that mid-period. And so when risk and rate are small, the differences between the rate and that corresponding risk are also probably going to be pretty small. So let's try to make sense of all this by applying this back to our example of population C. Remember, this is the one where the rate of death occurred pretty evenly throughout the year. So again, no big spurts of death in either beginning or end of the year, but consistently all the way throughout. And again, their mortality risk was 10%. So looking at this, if we were to calculate what their rate would be, we can look at the mid-period population, or this is going to be our basically the number of people who are alive at that mid-period point. And so we know that the total risk for the year was 10%. We can see that at in the middle of the year, 5% of those people would have died, right, of the total population. So you'd have 0.95 left over, right? 95% of that population is left. So again, here our numerator is going to be 0.1, or 10%, divided by that 0.95. Again, you can get that by doing 1 minus 0.05. That's the number of people who had died there. So again, 0.1 divided by 0.95, and that would equal 0.1053. So again, that number is not super useful for our purposes. So we could say, if we multiply by a constant, in this case would be 1,000, we could say that looking at population C, we would expect 105.3 people to die per 1,000 persons per year. So if you had 1,000 people in that nursing home in a year, you'd expect 105 of them essentially to be dead on average. Not great rates for a nursing home, but let's just continue running with this example. So again, in this example, the denominator is 0.95 because 95% of the population was still left at that mid-year. What you'll notice is that the yearly rate is higher than what the actual yearly risk is going to be, because the average population is smaller than the initial population at risk. Because again, if you were to look at calculation of risk in this case, it would be 0.1 over 1, or 10%, right? Our risk, we already said right here, is 10%, versus what we're getting over here is basically 10.53%. So rate is a little bit higher, and again, we're only looking over a 1 year time period. So this rate is a pretty good estimate of the actual risk. Let's see what happens when we start to look at a longer time period and see how the rate changes. So going with that same rate of 0.1053, let's look at population C at the end of 2 years. Now you can't just simply multiply that 10% risk times 2 because you wouldn't just have 80% of the population left over. That same 10% applies to that smaller population at the beginning of year 2, right? Similarly, the cumulative risk of death over 10 years can't be calculated just by multiplying by 10, because otherwise you'd have 10% times 10 would be 100, and all the population C would be dead at the end of 10 years. We know that would not be the actual case. However, we're looking at the mortality rate and that remained constant, you would see that that cumulative risk at 2 years, 5 years, 10 years, and 15 years would be, again, increasing between, say, at 19, 41, 65, and 79%. Again, there's going to be a straightforward way to determine that cumulative risk for any number of years, which I'll show you right now. And so basically what we can do is a calculation of a cumulative mortality risk in a patient with a constant yearly mortality rate. So what we're going to do is start off with our beginning data. We'll say population C had an event mortality risk throughout the year and a total yearly mortality risk of 10%. By the middle of the year, death obviously had occurred in 5%, right? Because we saw that average death occur all the way throughout the time period. Here we're going to see that mortality rate, again, by figuring that out, is 105.3 per 1,000 persons per year. So we already calculated that in slide or two ago. So again, if we know that rate is going to remain constant, how can we apply that to multiple years? So we can look at that. So the way we're going to do this, and I won't actually ask you to calculate this on a test, but this is kind of a way we can utilize logarithms to apply this over a period of time. And so essentially what we can say is that R is going to be our risk. T is going to be the number of years that we're actually interested in. So again, your risk for a total number of years. E is going to be the base of natural logarithms. And then you're going to use mu there as the mortality rate. And then T is obviously our time again, multiplying it by. Actually, we do the same sort of calculations when we're actually doing pharmacokinetic analyses, when you're looking at half-lives of drugs and how quickly someone can metabolize a drug. So actually very similar theory that goes into this when we're doing this, for pharmacokinetics or people, dying or having some sort of event. So if we were to look at this calculation, you can see that for 2 years, if we were considering what is that kind of cumulative mortality risk here, you'd say 1 minus e to the negative 0.1053. Again, that was our rate that we were concerned about previously. You see the rate here times 2, so we're looking at 2 years. Multiply all that out, and basically you would end up getting 1 minus 0.8101, and so you end up getting 0.1899. So essentially that rounds up to about 19% risk of death in 2 years. Again, it's not the same as the risk of 10% per year, because again, that population keeps shrinking as more and more people are dying off. So because of that, this is a much more accurate way of doing things than just saying that at the end of 10 years, 10% every year, everyone's going to be dead. That's not really what happens. But by utilizing this, you can say, okay, well, let's take into account the fact that more people are going to be dying as the time goes on. What's our cumulative risk over this time period? So looking at these different calculations based on what we saw in the formula on the previous slide, you can see here that again in 1 year, the cumulative risk of death was 10%, right? Again, at 2 years, you can't just multiply 10% times 2. It's not 20%. It comes out to be 19%. Close, but still not the same. Again, at 5 years, if you just multiply 5 times 10%, you'd expect 50% of everyone to be dead. That's not really the case. What it actually works out to be, doing that calculation, is 41%. So again, the farther in time you go as that population continues to dwindle, you're going to have increasing kind of errors in your estimates if you're just to multiply the risk times the time period. Again, this is all, utilizing that rate to help us out with this. So again, by 10 years, again, it's not just 10 times 10%, otherwise it'd be everyone would be dead. But here you notice it's actually 65%, and then by 15 years, you say 79%. So having this information is useful because you can say, well, in 15 years time, what is the risk that someone will have died or experienced whatever event you're kind of curious about. So again, to be valid, a rate has to meet certain criteria with respect to kind of this correspondence between the numerator and the denominator. So first of all the events counted in that numerator must have happened to people in the denominator. You have to make sure that you're actually looking at the population that you consider to be your denominator, and the people that had the event actually came from that. And then people being counted in the denominator must have been at risk for the event in the numerator. Right? So for instance, if you're looking at, say, the number of people who develop cervical cancer, your denominator probably shouldn't count men, right? Because you want cervixes to begin with, at least as far as I know. But before those comparisons of rates can be made, you must also make sure these are true, that the numerators for all the groups being compared must be defined or diagnosed in the same way, because obviously, if you're looking at AIDS diagnoses from, say, 1985 versus, say, 1995, that'd be pretty different, right? So that wouldn't really be comparable. The constant multipliers need to be the same, so you don't want to use, say, per 100 people years versus 1,000 people years, because you want to make sure those are consistent. And the time intervals have to be the same, because obviously you see over longer periods of time that rate can change pretty significantly. The numerators may not be easy to compare if the quality of that medical diagnosis differs over time. So kind of what we mentioned with that AIDS diagnosis previously. But for example, when you're looking at, say, like the late 1800s, we didn't really have an idea of what myocardial infarction was, but a heck of a lot of people were dying of acute indigestion, right? Probably not a lot of people dying of that nowadays. But by 1930, the situation was kind of reversed, where no one was dying of acute indigestion, but many people were dying of myocardial infarction once we kind of had a better idea of what people were really dying from. So it's tempting to say that acute indigestion was really myocardial infarction, but we can't really say that with any kind of certainty. What if they were having, say, some other event that was occurring that wasn't really myocardial infarction? It's difficult to kind of retrospectively apply that definition. Another good example of some of these problems in studying causes of disease over time relates back to the classification systems that we use. So for instance, in 1948 is where we had a major revision for the ICD codes, or the International Classification of Diseases. That's that coding manual that we use for classifying diagnoses. This is how we do a lot of our billing and things like that. And there's been several changes that happens over time. And so because of these changes in the classification, you saw major changes in the reported numbers of rates of many different types of diseases. And so it's difficult to track changes because of that. It's also difficult to kind of make fair comparisons looking at these different time periods between populations, between countries even. And then looking at things like different nations having different degrees of access to healthcare, or different levels of quality of healthcare, available to most people who are dying, different styles of diagnosis, things like that. It's very difficult to make these kind of apples and oranges kind of comparisons. And nowadays we're on the ICD-10. So again, even from going from ICD-9 to 10, like, you can see some differences here in how certain diseases may be reported or categorized, which can change your rates pretty significantly. So a few more definitions regarding rate. We have incidence rate and then also prevalence rate. Incidence rate is usually going to be the number of incident cases over a defined study period. So again, the new number of incident cases is your numerator divided by that population at risk. Again, usually expresses either per 1,000, 10,000, 100,000 population per year, or whatever your time period happens to be. Prevalence rate, on the other hand, is more of a proportion than an actual rate, and it's basically used here to indicate the proportion, again, usually as a percentage, of people with a defined disease or a condition at the time they end up being studied. We use prevalence rates more frequently for things like risk factors and to diseases or kind of other conditions, right? So typically what you're going to see more often is probably the incidence rate being reported. Now we can have incidence density, and this actually refers to the frequency. Again, just another name for density of new events per person per time. So again, person months or person years. And so this can refer back to events that can happen more than once, for instance. So example here is we're looking at, say, 3 patients who were followed after they got a tonsillectomy and adenoidectomy, and they were looking at recurrent ear infections. So here they were looking at one patient who got followed for 13 months, one was for 20 months, and one's for 17 months. Even though they're followed for different periods of time, they can still be kind of compared together. And they had 5 ear infections that occurred in these 3 patients during the time period. Basically, that incidence density would be 5 infections per 50 person months of follow-up, right? Or you could say 10 infections per 100 person months, right? Because basically, if you add these up, you'd get 50 months total, 5 infections per that 50 months. Okay. Again, this is going to be useful for things that happen more than once during a study period. So usually we're going to be using rates and risks to make kind of one of 3 types of comparisons. The first one is going to be between an observed rate or an observed risk with a target rate or risk. So for an example of this, we'd see, like, say the U.S. setting a national health goal for 2010. we're wanting to look at various types of death and things like infant mortality rate. And so what we can do is use final statistics that get published, and we can compare the observed infant mortality rates for the nation and kind of compare for different subgroups and things like that to see, like, okay, where are the issues at? Where are we having some deficiencies here, or maybe who was doing the best, right? And see how they met up with those objectives kind of set by the government. So that's one way we can do or observe rates and risk and how we can utilize them for comparison. The second type you can do would be comparisons between two different populations at the same time. This is probably the most common example of this. So for instance, if you were to compare, say, rates of death or disease in, say, two different countries, so you're looking at the US versus the UK, or if you're looking at different states or ethnic groups, you can compare the results in the treatment and control groups participating in a randomized controlled trial, right? So, the rates of myocardial infarction in people who received a beta blocker versus those who received placebo. This is a major research concern here, is when we want to ensure that the two populations are similar and they're going to be measured in exactly the same way, right? So again, if you're comparing, say, two different countries, like, well, how are the populations different? That may have an effect on your results, and are they being measured exactly the same way is the other big concern. A third type would be comparing the same population but a different time period. So this is kind of good for studying different time trends. So if you're to look at, say, things like the increasing proportion of the elderly in the U.S., or things such as infant mortality rates between, say, the 50s to now. Obviously, the concern over here is kind of your definitions and how you diagnose things. Obviously, with better diagnostic capabilities, you tend to find increased incidence of certain conditions because we're catching it better, right? Another thing to be considerate of is when you're looking at rates is kind of three subcategories of them. There's crude, specific, and standardized. When we apply rates to an entire population, kind of without any kind of reference for the characteristics of the individuals in it, so say you're looking at the whole U.S. population, we consider this to be a crude rate. However, when you take a population, divide it into more, say, homogeneous subgroups. So for instance, you base it on age. So say people 60 to 70, 50 to 60, 40 to 50, etc. Sex, race, risk factors, anything like that. The rates get calculated here within these groups, and they can be called specific rates. So you can see age-specific rates or sex-specific rates. Okay, and then we'll talk about standardized rates a little bit later in this course. Now, crude rates can be valid rates, but they're oftentimes misleading, which can lead you to see why they're kind of named crude, right? So, for instance, if you were to try to guess which of the following countries between Sweden, Ecuador, and the U.S. has the highest and lowest crude death rate, which one would you guess has highest and lowest? For 2004, you would find that Ecuador had the lowest crude death rate and Sweden the highest. Even though Ecuador has the highest age-specific mortality rates and the shortest life expectancy, and Sweden had absolutely the reverse. This apparent anomaly is really occurring because you're only looking at the crude death rate and not really taking into account the effect of age. Basically, when you're looking at a population with a really young age distribution, such as Ecuador, say where they had a median age of 23, the birth rates are likely to be relatively high, and you're going to find that crude death rate is going to be pretty low. So even though they had a shorter life expectancy, a lot of those people, when they're younger, tend to stay alive, right? A lot of people were not dying necessarily. On the other hand, though, when you're looking at a much older population, say as Sweden, they're going to have a lower crude birth rate, I should say, because again, with an older population, not as many of them are reproducing. They're going to have a high crude death rate just due to the fact that they're an older population. So because age has such a profound influence on that force of mortality, you need to really take that into account. Even if you have a relatively healthy older population, they're still going to have a lot higher death rate. 70-year-olds are going to have a lot higher death rate than a 20-year-old. It's just kind of the way of the world. And so it's really important that investigators really should not make comparisons on the risk of death or disease without controlling for age. That's kind of one of the first things you always need to control for is going to be age. So again, looking at just the crude death rate of these different populations, you can see here that in 2004, Ecuador had about a crude death rate of 4.6 per 1,000, US was 8.3 per 1,000, and Sweden was 10.4 per 1,000. Even though looking at the life expectancy, Swedish people tend to be living longer than people in Ecuador. So why would you ever use crude rates, not just use specific rates all the time? There could be some circumstances where this isn't really possible to use specific rates. So for example, if the frequency of your event that you're considering, your numerator, is unknown for the subgroup. So if you didn't know what the, say, death rate for 20-year-olds versus 50-year-olds was, based on your data, you wouldn't really be able to make a specific rate, right? If you have the size of the subgroups is not really known, you don't have that denominator now, that would be impossible to calculate a specific rate. Or if the numbers of people at risk are too small to really provide you any kind of stable estimates, like if it's so small that it could change pretty significantly from time period to time period, that also not be super useful. So basically, if that number of people at risk is large in each of the subgroups of interest, then specific rates do provide the most information, way more than a crude rate would just provide. And so again, although we can look at the biasing effect of age, we can control for this in many different ways. The simplest way we can do this is to calculate an ASDR, or this is also known as an age-specific death rate. And we can use this to compare similar age groups. Basically, we look at the formula as such, where our age-specific death rate, or ASDR, is equal to the number of deaths to people in a particular age group. So we're going to define that, usually, say, 70 to 80-year-olds over a year period or whatever, divided by that mid-period population. Again, very similar to what we saw with the rate calculations before, and say maybe multiply by 1,000. You could do 10,000, you could do 100, but usually 1,000 is probably the most common. If you were to think about it, crude death rates are basically just the sum of all these different age-specific death rates in each of the age groups, weighted by their relative size of each age group. So for instance, with the Swedish population, their older population makes up a higher proportion than Ecuador's aged population. And so it's going to have a higher effect on that rate of mortality. And so you can basically look at the underlying formula for this kind of summary rate. This kind of crude death rate equals the sum of W sub I multiplied by R sub I, where W sub I is going to be the individual weights or proportions for each age-specific group multiplied by the rates of the corresponding age group. I'll show a more specific example in just a second here, but the formula is pretty useful for understanding why crude rates can be pretty misleading. If you're looking at two different populations, and if the relative weights or the sizes of the old and young populations are different, you're going to find that they have pretty different ASDRs. They'll have different weights to them, and so you can't really make a fair comparison without looking at these individual subgroups. You'll find a similar problem occurs when you're trying to compare death rates between different hospitals to measure the quality of care. To make fair comparisons amongst hospitals, you have to make some adjustments for different things, different features, like the type and severity of illness and the surgery. And the people that are being treated, right? Otherwise, you can have people that hospitals that take care of the sickest people would kind of be an unfair disadvantage. For example, if you were to compare, say, infant or neonatal mortality rates between, say, like Arnold Palmer Hospital versus Nemours, I would probably venture to say Nemours has a higher infant or neonatal mortality rate. And the reason for that is because APH, they have a birthing center there. They have a lot of really healthy babies that get born to that hospital. Not many of those neonates tend to die. Versus over at Nemours, we do not have a birthing center there. We only have transfers from other hospitals of neonates into our NICU. Because of that, no one transfers a healthy NICU baby over to our NICU. They tend to go home. We only get the sick ones. And so because of that, you would kind of predispose us to having higher, say, neonatal mortality rates, unless you took into account the fact that we were getting sicker patients. So, and again, those standardized rates, we can also call these adjusted rates. They're just going to be crude rates that have been modified or adjusted to control for the effects of age or other characteristics that kind of allow us to make valid comparisons between different groups. If we wanted to get like a summary death rate that is free from age bias, we can use what we call an age standardized or an age adjusted crude rate by either a direct or an indirect method. We'll talk about those methods here in just a second. Generally, standardization is going to apply to death rates, but you could probably use it to just about any type of rate, as long as you have the correct information about these subgroups. A direct standardization is probably the most common one, where we're going to use a method to remove the biasing effect of different age structures on the different populations. This kind of direct method, we can use the ASDRs of the two or more populations, and we're going to compare, or they're going to be compared to one another, and apply them to a single standard population. Right. So again, kind of taking out the bias of the population itself, and just utilize these different rates. Basically, you do this by multiplying each ASDR from each population to be compared by the number of people in the corresponding age group in the standard population. Now, because that age structure of that standard population is going to be the same for all the death rates applied to it, it doesn't matter which country you're looking at or which group you're looking at, that distorting effect of having different age distributions is basically going to be taken out of the equation. And again, that's why we call it standardizing. It kind of eliminates that bias there. And so the standard population can be any real or at least a realistic population. And typically it's going to be a larger population in which of which the populations that we're being compared are taken out of. So a good example of this would be if you're looking at death rates of two different cities in a state, you can basically compare these two cities using the state's population as kind of a standard, right? Again, you're kind of pulling from a similar population, it's just much larger, and you're taking away these effects of bias to kind of get an apples to apples comparison. So that direct method is going to show us the total number of deaths that would have occurred in the standard population if we apply those ASDRs of the individual populations had occurred, right? So we're basically saying like, well, if you took these numbers and applied it to the whole population of the state of Florida, for instance, this is what it would look like based on Orlando's data versus Jacksonville's data. And then we can see like, well, what do they, death rates look like between the two, which on a standardized basis, which one has higher death rates? So we're getting this again by taking the total expected number of deaths from each group of the comparison populations, and then we divide that by the standard population to give us a standardized crude death rate. And then we can use that basically compared to any other death rate using the same standard population, right? So in the case of the Jacksonville versus Orlando example, if you're applying it to the state of Florida, you could do Tampa versus Daytona or whatever comparisons you want to make, as long as it's to the same standard population. And so you don't have to use this just for death. You could use it for rates of disease, injuries, whatever you want. And then keep in mind these are kind of fictitious rates. They can't be applied back directly to that city or whatever example population you're looking at. But they're going to be what-if rates and allow us to kind of make these comparisons more fair than they would be if we just use crude rates without taking into account things like age. So we're going to look at a kind of simplified example shown in the next slide where we have populations A and B, and they get divided into young, middle-aged, and older people. And we're going to look at specifically their ASDRs for each age group. And we're going to see that in population B, those ASDRs are going to be twice as high as that for the corresponding age group in population A. Right, so ASDRs are higher. And then in our example, standard population is going to be the sum of the two populations compared together. Again, we kind of set what we want the standard population to be. Population A is going to have a higher overall crude death rate, which we're going to see here is going to be 4.51% than population B, despite the fact that the ASDRs in B are higher, but we're going to see that how that works out with the population breakdown. But after that death rates are going to be standardized, that adjusted death rate for population B will correctly reflect the fact that ASDRs are higher than population A. So this looks like a lot to take in, but just kind of go with it. So again, we're going to figure out what our actual crude death rates are going to be. So we have to do the calculations first to figure out what it is. Again, population A is going to be on the left side here, population B on the right side. Age group is broken down into young, middle-aged, and older. Notice here that as far as our population goes with population A, these tend to skew middle-aged and older, right? So only 1,000 people in the young category, 5,000 middle-aged, 4,000 and older. Versus the population size over in B, you're going to see that this skews much more towards the young, where they have 4,000 in the younger population versus only 1,000 in the older, okay? So looking at the age-specific death rates, I can see here what they are. Again, B is going to be twice as high. When you actually look at the true crude death rate here, if you actually multiplied all this out, you would see that it looks like the crude death rate is much higher than population A than B, even though the ASDRs are higher in B. So again, because these are apples to oranges comparisons, we want to compare this if you were to take out the effect of age on these calculations. So what we can do is now combine these populations together. So again, you'll notice down here when you're looking at this, you have 5,000 in the young category, 10,000 in the middle-aged, and 5,000 in the older. Again, just A plus B, essentially. By applying the age-specific death rates to this kind of combined kind of fictitious population, we can see here that the actual standardized death rate is lower, or roughly 1/2 of what the for A of what B is. And that kind of makes sense. And again, this allows us to make more fair comparisons, taking into account the fact that one population may skew older or younger than another. There's also an indirect standardization that can be used if you have ASDRs that are unavailable in the population in the crude death rate that you want to be adjusted. It's also it can be used if the population to be standardized is pretty small, which can make ASDRs pretty unstable. You know, they could change pretty drastically from year to year if you're dealing with a small population. And so the indirect method uses standard rates and applies them to the known age or whatever categories you're looking at in the population to be standardized. So let's say, for example, we wanted to figure out, say, an investigator wanted to find out if death rates, say, for male workers in an offshore oil rig, and see how those death rates compare to death rates for the U.S. population. Again, people on this offshore oil rig in this company would be relatively small numbers. We probably wouldn't be able to get very accurate ASDRs, but certainly we know what the ASDRs would be for the U.S. population. So again, we can take those numbers from the population, apply them to this company, the subset of men based on their age groups and whatnot, and determine, how does that compare? Are they dying more frequently for their age respective groups than the U.S. population, or maybe are they dying less often? So we can figure that out using an indirect method. To start off with, we're going to need the observed crude death rate and the ASDRs for the U.S. men for a similar year, right? These are going to be our standard death rates. And then we would determine the number of male workers in each of the same categories used for the U.S. male population, right? So again, we would look at the male workers in the offshore oil rig, and we would figure out how they fit into those categories using that male population. So if you did younger or middle-aged, older, or if you did 10 to 20, 20 to 30, whatever happens to be. Although I don't know how many 10-year-olds would be working an offshore oil rig, but maybe it happens, who knows. Basically, though, that investigator would determine the observed total deaths for 1 year for all the male workers in the company based on the standard death rates from the U.S. and see how they compare with the actual death rates. The first step for this method is to multiply that standard death rate from each age group in the standard population, which would be the U.S. population, times the number of workers in the corresponding age groups in the company. That's going to give us the number of deaths that would be expected if all those men in those age groups died at the same standard rate that would occur based on the U.S. Population ASDRs, right? And then the expected numbers of work deaths for the various age groups are then added to obtain the total number of deaths that would be expected for the entire work group, right? So even though we don't have the ASDRs for each individual group for the company workers, if they were the same as the U.S. standard population of men, like how would they compare? In the next step, we take the number of observed total deaths among the workers. This is going to get divided by the expected total deaths. And so basically what we're going to get is this ratio called the standardized mortality ratio. And I promise this will make more sense when we look at the chart. Basically that standardized ratio gets multiplied by 100 to eliminate any kind of fractions. So that way we would know kind of what the mortality rate is among standard population, assuming that equals 100, we end up getting, this ratio kind of gives us an idea of how much above or below these workers are going to be compared to the U.S. male population. So for example, if we had a standardized mortality ratio of 140, it would mean that their mortality rate was 40% greater than what would be expected based on those age specific death rates of the standard population. So as I mentioned, this makes more sense when actually looking at the graph here. We can see that when you're looking at the beginning data, we have our men in standard population, so this would be the U.S. population versus the men in the company. Notice here we don't have any of the age-specific death rates. We don't have our reserved death rates based on that, right? But we do know how they kind of have their breakdown into young, middle-aged, and older, right? So we know this breakdown. And so for the standard population, we know this proportion of the standard population, about 40% fall in this young category, 30% in middle age, and 30% in older. So again, total ends up being 1 here. And we know what the age-specific death rates are going to be for the population. We had this from Census Data, et cetera, right? So basically, if we were to take this information, we want to apply this over to what would happen, like, assuming these guys were dying at the same rates as the U.S. population, what would their death rates look like? And so that's what we're going to do to get the standardized mortality rate. So again, here in the male workers, we know that roughly 48 per 10,000 were dying, or 480 per 100,000 men were dying, say, per year, right? Versus this 334 per 100,000. So we want to figure out, okay, how are these comparable? Let's see, because it would appear, just based on numbers alone, 480 is bigger than 334, that these men in the offshore oil rigs were more likely to die, right? They had a higher standardized death rate. Let's see if that actually bears out. So what we're going to do is take basically these rates here and apply it and say, well, if you had the men in the offshore oil rig, if they're dying in the same rates as the men in the standard U.S. population, what would the number actually look like? So if you apply this through, and so we see this observed death rate, which is basically just that proportion times 0.001, and basically apply that to the number of workers here, you end up getting the proportion of kind of observed deaths, or proportion of observed deaths here. So you end up getting a total of 53.2 per 10,000, or equals out to be 532. So assuming that the men in the oil rig, again, based on their age breakdown in these different categories, if you apply that the standard population ASDRs to that, you would have expected 532 to have died per 100,000. Now all of a sudden we're seeing that it looks like that based on the US population ASDRs that more of them should have died than what actually had occurred here, right? So 532 versus 480. Now that we can take that, we can divide these numbers, take this this 480 divided by this 532 essentially, or if you look at this, if you were to take just the actual fractions here, or decimals, do 0.00480 divided by 0.00532 times 100, and roughly end up getting 90, right? So this would mean that actually the men in the oil rig, they had a 10% or 90%, I should say, chance of dying compared to the standard population. So basically a 10% reduction in their risk of death. So later on, investigators could go through and try to figure out why that is. Maybe their diet's different. Maybe they have different work-life conditions. Who knows what happens to be? But again, just based on these numbers alone, it would appear that these men are more at risk when actually they're dying at a slower rate, or the risk of death is lower than what would be for the standard U.S. male population. So hopefully that makes sense. If not, you can always send me emails. We can talk about it more in depth. Another type of specific rates we can get are going to be cost-specific rates, and so although we can create age-specific, sex-specific death rates, kind of make our denominators more homogeneous, right, and allow us to compare different groups. What we can actually do is use cost-specific death rates to make the numerators more homogeneous, according to basically the diagnosis that we're going to be setting. And so by doing this, by comparing these cost-specific death rates over time, or say like between countries, it can be pretty risky since there can be a lot of differences in things like diagnostic styles, or say like the efficiency between the healthcare that's provided in different countries. And so, for instance, in countries where they have inadequate medical care, 10 to 20% of deaths may be signed out as a symptom, signs, or ill-defined conditions, right? So kind of an unknown cause of death. And you can see this actually happens among people who die without adequate medical care in the U.S. If we can't target a specific cause, it's kind of unknown causes, right? And so a cause-specific death rate could be would have basically the following form. Basically, you can come up with the number of deaths due to a particular cause, and again, define place, time period, and divided by the mid-period population. So again, it's going to homogenize our numerators rather than homogenize the denominator here. So the next slide is going to provide some data on leading causes of death in the U.S. For 1950 and 2000 that gets reported by the NCHS, and this is going to see some of these underlying causes of death indicated on these death certificates. Rarely is this data ever accurate enough for true epidemiologic studies for causal factors, but it can kind of give us an idea of these different disease groups kind of relative to one another, see how those trends are going. Again, you can't really glean a whole lot of actual causative data here, but you can look for trends, which can be useful. So here on the slide, you can see how we have cause-specific death rates. You can look at things like cardiac disease, homicide, HIV, etc., and look at these comparisons between, say, like 1950 to 2000. Again, these are age-adjusted, so taking that effective age out of this to make sure, again, comparing kind of apples to oranges, because obviously the population in the 1950s was probably skewing a lot younger than it was in 2000s, as we had having an aging population, baby boomers and whatnot getting older as time goes on. And so again, certain things may not show up early on. So like HIV was unheard of in the 1950s versus in 2000. Some things will become less likely to be a cause of death. I think that cardiac disease gets better as we get better treatment for it. But certain things like cancer tends to be pretty similar rates, right? So again, useful for trends, maybe not great for looking at any true causative data here, but can be good to look at occasionally. So last thing we'll look at today is going to be some commonly used rates, one of which is some good ones that kind of help us to reflect both maternal and infant health. And again, this is useful because it's kind of a good surrogate for looking at kind of overall health of a population. How good or how well are we taking care of our mothers and the babies? And so their survival rates are a good rate that we can look at that. And so because talking about infant death is kind of a bummer, I wanted to at least put up a picture of my little girl Lily. This was when she was 1 day old. Again, this was more relevant last year after she was, still pretty young, but nowadays she looks a little bit more like this and very, very cute. And next year I'll probably end up having a new picture of my next baby, assuming everything goes well. But anyway, what we can see here is that these kind of international definition, and this is important that it's international so that the definitions get applied the same in the US to the UK to the Middle East to Japan, everywhere else, right? And so a live birth is going to be a delivery of a product of conception, kind of an odd way to talk to about a baby that shows any kind of sign of life after complete removal from the mother. This can include things like a breath, a cry, movement, pulse or heartbeat, and kind of pulsation of the umbilical cord. It's considered to be a live birth. And so typically we will look at fetal deaths as being categorized as early, intermediate, or late, depending on when they were born, essentially. So like an early fetal death, oftentimes known as a miscarriage, occurs basically when a fetus gets delivered within the first 20 weeks of gestation. International agreements on kind of the intermediate cutoff point here is going to be when a dead fetus is delivered between 20 to 28 weeks of gestation, and if fetus born dead at 28 weeks or later is considered to be a late fetal death, better known as a stillbirth. And so an infant death is going to be the death of any kind of live-born infant before the first birthday. And then neonatal death would be the death of a live-born infant prior to the first 28 days of life, right? And then a post-neonatal death is going to be the death of an infant between that 28 days up to the first birthday. So again, it's important you keep the definitions consistent to make sure that you're comparing apples to apples between, say, different populations. And so we can look at accrued birth rate is going to be the number of live births divided by that mid-period population. So again, the rate here is going to be very similarly calculated as what we've seen previously. Now, basically, we can look at these different death rates as kind of surrogates for different things. So, for instance, because the health of infants is unusually sensitive to maternal health practices, right? So, if a mother has poor nutrition or is using tobacco or illegal drugs, things like environmental factors and quality of health services, infant mortality rate oftentimes gets used as an overall index of health status of a nation, kind of like I was talking about previously. And so this infant mortality rate has the added advantage of also being available for most countries and for being pretty age specific, right? Because it's very easy to track the age of a baby, and most people are pretty good at capturing these births. I mentioned sometimes there can be some error here in not capturing all births, but hopefully most of these kids are getting born in hospitals and you can capture that. And so here you would see that numerator and the denominator of the infant mortality rate gets obtained from those vital statistics reporting, as I mentioned, usually from the hospitals up to the Department of Health, up through CDC, things like that. And so the way we calculate that would be basically the number of deaths to infants. It's going to be less than 1 year of age, right? So there's the infant mortality rate divided by that number of live births. At the same place, same time period again, so you need to make sure to keep those comparisons correct, and then usually times 1,000. So you'd have so many ever deaths, per 1,000 births. Now, one thing to note is that most infant deaths typically occur during the first week of life and are typically due to things like prematurity or intrauterine growth retardation with kind of resulting immaturity, which oftentimes leads to things like respiratory failure. That's usually the thing that ends up being the cause of death for a lot of these kids. Some infant deaths are going to be due to congenital anomalies and things like that as well. One point to note, though, is that when you're looking at infant mortality rate, that depending on what time of year a baby is born, you may find that infant may die. You may be born in 2005 and won't die until 2006. Or for instance, like my baby is going to be due on December 25th, a little Christmas baby. And so she may not actually be, counted if something unfortunate were to happen to her. Like there'd be that year cutoff point. So to account for things like that, you typically look at infant mortality in these small populations over say like a 3 to 5 year period. Larger populations is probably not going to be as big of a concern because those babies kind of on the cusp there will not be as big of a factor. So you can, again, calculate neonatal and post-neonatal mortality rates, very similar to what we saw with some of the infant mortality rate. For neonatal mortality rate, it would just be basically the infants that died less than 28 days of age divided by that number of live births, so pretty straightforward. And then for a post-neonatal mortality rate, so again, this would be kids that had died greater than 28 days, so past that neonatal period prior to that year birthday. And so basically you just end up taking the number of deaths that occurred during that time period, divided by that number of live births minus the number of neonatal deaths. Again, you want to count those kids that died in the first 28 days, and then that would be kind of your remainder of live births there. Now, if you're dealing with somewhere like the U.S. where you have a relatively low neonatal death rate, say less than 5 per 1,000 live births, you can use this kind of a approximate formula as pretty adequate for kind of getting your post-neonatal mortality rate. So if you were to take, say, the infant mortality rate minus the neonatal, you should get most of those kids that kind of fall into that time period between 28 days to 365. Now, the reason we look at this feature is because, like with neonatal mortality, that usually is going to be a reflection back on medical services and of like maternal prenatal behavior. So like if they're doing drugs or alcohol, things like that. Whereas a post-neonatal mortality tends to be a reflection of the quality of the home environment. So if they did something like had let the baby sleep on its stomach, or they had a bunch of stuff in the crib that led to eventual suffocation, like all of that could be more related to the environment necessarily than how the mom took care of herself during the actual pregnancy. So we can also look at pregnancy-related deaths. Obviously, pregnancy is a pretty normal biologic process, at least for 50% of the population, roughly. But we can see that puts a pretty considerable strain on a pregnant woman and kind of puts her at high risk for numerous hazards that she would not face otherwise had she not been pregnant. So hemorrhage, infection, toxemia, things like that. And so due to some of the complicated course of some of these conditions, things like heart disease, diabetes, TB, because that can have an effect here, we can look at the progress of it for a nation, as far as providing adequate care to these women based on the maternal mortality rate. So how many kind of complicated pregnancies we're having where these women are dying could be another sign of like how well that a nation is providing care for those mothers. Basically, you would calculate this as being the number of pregnancy-related deaths, again, of the women that were pregnant, divided by the number of live births. And then you again multiply by 1,000 or 100,000 to get kind of the standardized rate there. So that equation is going to be based on the number of pregnancy-related deaths that occur. And so obviously, if a woman had died, say, of automobile injury or something like that, or if it was the woman died outside of the delivery, you really wouldn't consider that to be pregnancy-related in these cases. So what we do is we change our denominator from just the number of pregnancies, we change it to the number of live births, right? So it's kind of, for simplicity's sake, it probably gets us a little bit closer to ruling out some of those deaths that are really unrelated to the pregnancy itself. We're using 100,000 because in really the recent decades, we found that maternal mortality rate in many countries has declined to less than 1 per 10,000. So again, it's a good sign. So we have to use a higher kind of multiplier there in order to make sure that we can make sure the numbers sound correct. So for instance, in 2001 in the U.S., our maternal mortality rate was 8.2 per 100,000 live births. Okay, you end up finding that things like the rate for whites was lower than all their races, but for Black Americans, the rate was 20.1 per 100,000. So, this is useful because it kind of gives us an idea of like, well, okay, what are the differences here? Are there other investigations we can do based on this information? Are there certain interventions that could be provided, certain, kind of public health or behavioral interventions that we can make to try to shore up those numbers? And so again, this usually provides kind of good food for thought and good kind of research idea generation for future studies. All right, so that's going to do it for this section. If you have any questions, please feel free to go ahead and send me an email. We can certainly talk about it anytime. Until then, I will see you next time. Have a good one. Bye.